talk today for physicians about the update in the treatment of hepatitis B virus. As we know, the hepatitis B carriers, about 25% inactive carrier, but reactivation to the active HBV about 1 to 2%. When active HBV is progressive, therefore, the hepatitis B virus is progressive disease. It starts by chronic hepatitis to cirrhosis and hepatocellular carcinoma. This depends on the viral load. When the viral load is high, the possibility of cirrhosis is high. When the viral load is low, the possibility of cirrhosis is low. Also, the hepatocellular carcinoma depends also on the viral load. When the viral load is high, the possibility of hepatocellular carcinoma is high. When the viral load is low, the possibility is low. The hepatocellular carcinoma may occur even after treatment of viral B hepatitis. Therefore, anyone has viral B hepatitis, take care to follow the development of hepatocellular carcinoma by alpha-fetoprotein and the ultrasonography. Therefore, if we suppress the viral load, we can prevent the development of cirrhosis and the development of hepatocellular carcinoma. But as I told now, the hepatocellular carcinoma may occur even with normal enzymes, even with the hepatitis B virus treated. Therefore, when we want to start the treatment, there are 3 parameters: the activity of chronic hepatitis, the high the HBV DNA PCR, the higher the ALT enzymes. Because the low ALT or normal ALT, the response to treatment is less than the elevated ALT. This is laparoscopic picture denote the chronic active disease progressing to early cirrhosis. On liver biopsy, we can detect the hepatitis B as a ground glass appearance in the cells, and this is more clear than before, and this is denoting the activity of hepatitis B virus. Therefore, the liver biopsy, is it essential for the diagnosis, or something else may replace it? Okay, there is something else. We denote the effect of the virus on the liver by fibroscan. Therefore, this is the parameters as I told you, but some experts have suggested that all patients with chronic hepatitis B virus should be treated. Whatever the level of ALT, whatever the level, the viral load, the fibrosis, all patients should be treated. They are at the risk of cirrhosis and hepatocellular carcinoma because some patients developed cirrhosis and hepatocellular carcinoma without the parameters and the criteria for the treatment. ولكن spontaneous clearance is possible. The treatment is expensive. Long-term safety of the drug is not established. But in the future, in the coming years, we have the treatment which can eradicate the viral B hepatitis. When this is present, therefore, everyone should be treated from hepatitis B virus. Therefore, is the treatment options. Who should be treated? We treat the patients with cirrhosis, either compensated or decompensated, whatever the level of PCR, regardless of ALT level. When there is family history of hepatocellular carcinoma, antigen HBeAg positive or even negative, the normal enzymes, mild degree of fibrosis, we should treat these patients. When there is immune tolerant patients with HBeAg positive and persistently normal ALT, no or mild degree of fibrosis, high PCR level, treated if older than 30 years. Before, we always say older than 40, but recently it is older than 30 years, regardless of histological lesions. We treat when the PCR more than 2000 international unit, when the ALT more than the double normal, these patients should be treated. Therefore, when there is fibrosis, by a fibroscan, we find stiffness 9 kPa, HBeAg positive or negative, and the rise of LPCR should be treated. When there is HBeAg positive chronic hepatitis B, when they are younger than 30 years, no treatment should be followed up at least every 3 to 6 months. When the HBeAg negative chronic hepatitis B virus infection and the PCR less than 2000, follow up every 3 months for the first year and every 6 months thereafter. Therefore, patients on chemotherapy or immunosuppressive patient should be screened for surface antigen and core antibody prior to the initiation of treatment. When the HBsAg positive should receive oral antiviral therapy at the onset of chemotherapy and for 12 months after treatment if the viral load less than 2000 and short duration of immunosuppression, use lamivudine. When there is long duration or the treatment courses of immunosuppression repeated and the viral load more than 2000, use the Entecavir and Tenofovir. Why? Because the lamivudine may get the tolerance for when used for a long time, while the Entecavir and Tenofovir, there is no tolerance if used for a long time. The oral antiviral therapy start at the onset of chemotherapy and for 12 months after this cessation of treatment. Now we started the treatment, and the question now, when to stop the treatment? This is a problem for us. Stop treatment when the surface antigen loss, and this is not common, but it is rare, less than 10%. We stop the oral antiviral therapy in non-cirrhotic patient when EAG positive chronic hepatitis if HBsAg stable and undetectable PCR and who completed 12 months of consolidation, that is to say, on the treatment without reactivation of LPCR. We stop the treatment in selected cases, non-cirrhotic, when we achieve the response more than 3 years of virological suppression must be closely monitored to resume treatment when there is clinical relapse. What is clinical relapse? That is to say, reappearance of PCR and elevation of ALT. Because viral relapse may lead to hepatitis flare and hepatic decompensation. Take care when the viral relapse and lead to hepatitis flare and hepatic decompensation. We treat our patients, and there is suppression of a surface antigen, but it is not cure from infection. Why not cure from the infection? Because the surface antigen is still positive. When we say cure, when the surface antigen negative. All the treatment now cannot make a surface antigen negative, not more than 10%. In the future, there is new therapy make this surface antigen negative, but not available now. The persistence of surface antigen, it is not cure from the infection. The chronic hepatitis B, unlike hepatitis C infection, the hepatitis C virus replication within cytoplasm of the liver, in the cytoplasm of the liver. Viral eradication is possible, but the hepatitis B virus infection, the virus integration into the host chromosomes and replicate through a closed circuit. This is closed covalently circular DNA, which is known as cccDNA. What is this problem? This is the virus go inside the liver cell, go inside the nucleus, replicate. When there is replication, it go outside the nucleus to come again inside the nucleus, but also may go outside the hepatic cells. Therefore, so long surface antigen is positive, there is a covalently closed circle is present, and the virus persists, and there is no cure. Cure when the liver cell dead. But so long its surface antigen outside the liver cells in the blood. Therefore, it is not cure, it is suppression of the virus. As I told you now, the current therapy cannot clear cDNA. Therefore, it is persistent of the surface antigen. Therefore, you can measure cDNA. How? Measuring cDNA requires liver biopsy, and this is not possible. But what is possible? Therefore, we can make quantitation of surface antigen, and this is non-invasive. We make quantitation of surface antigen in the blood. Therefore, the quantitation of surface antigen can correlate with the cDNA. Therefore, quantitation of surface antigen is important. Therefore, it has a significance. When there is high surface antigen quantitation, therefore the development of cirrhosis, development of decompensated cirrhosis. When it is high, more than 1,000, the possibility of hepatocellular carcinoma. When it is less than 1,000, the possibility of hepatocellular carcinoma less, not more than 39. But when more than 1,000, the possibility is 95%. When the HBsAg quantitation low, there is for the possibility to predict the response to treatment. Therefore, we know now that so long the surface antigen is present, it not mean the cure, but it means suppression of the viremia. It means that the possibility of liver cirrhosis is less. It means the possibility of hepatocellular carcinoma is less. It means that the compensation of the liver is less. Therefore, we should start the treatment. The aim of the treatment is the suppression of the surface and of the PCR to avoid the complications of high viremia. What is the treatment? There are two recommended agents, Entecavir and Tenofovir. Why? Because low incidence of resistance. Entecavir, 0.5 milligram once daily for naive patients when the resistance not more than 1.2 for entecavir after 6 years. Tenofovir, 300 milligram daily. The probability of resistance 0 for 5 years. This is 2 drugs only? No. These drugs expensive, and we want cheap drugs for our patients. What is the cheap drug? Is lamivudine. Lamivudine, it is a cheap drug. We can give our patient. The response is good, ولكن the development of resistance every year 25%, but after 5 years or 4 years, it is more than 70%. Actually, I have many patients on lamivudine didn't develop resistance for 10 years. Therefore, if developed resistance, why not? Before, we add Adefovir together with lamivudine for 6 months, and to stop lamivudine and go on Adefovir for a long time, as Adefovir resistance is rare. Therefore, lamivudine resistance, we add Adefovir, but now the best treatment instead of Adefovir, tenofovir for lamivudine resistance, because it is more potent than Adefovir. But entecavir is not optimal for lamivudine resistance. Therefore, lamivudine first. If developed resistance, we instead of Adefovir, we give tenofovir and not entecavir for these patients, and not together, but to replace the lamivudine by tenofovir. Therefore, what is about the big interferon? The big latent interferon here for Egyptian patients, the response is poor because they always genotype D and the HBsAg negative. Therefore, the effect not than 30%. But big latent interferon for 48 weeks, if the HBsAg positive, ALT high, the seroconversion occur after 24 weeks of therapy. When there is seroconversion from HBsAg negative positive to HBsAg negative and developed HBeA positive, we can continue for 48 weeks. But after 24 weeks, if no seroconversion, we stop the treatment and shift to oral antiviral therapy. Therefore, big latent interferon is important for patients with HBeAg positive and high ALT, and for 24 weeks if response go on for 48 weeks. Now there is a trend, new trend. What is this new trend? There is now suggestion that monotherapy with single antiviral agents is unlikely to eradicate the virus, and suggested that the combination therapy is more effective than the monotherapy. Therefore, there is combination of lamivudine with interferon. This is possibility. There is another combination, tenofovir ma entrecavir, it is called Truvada. This is suggestion, but what is the truth? It has been found the combination therapy not provide more benefit. It provides reduction in the incidence of resistance. Therefore, the combination therapy is still in trials and study. Take care of this boxed warning. If you start the treatment, there is acute exacerbation of hepatitis B may occur upon discontinuation of therapy. Monitor function for at least several months after stopping treatment. Reinitiation of therapy may be required. This is a problem for me and for any doctor, because the patients coming to me and start the antiviral therapy without indication. I cannot stop the treatment because I am afraid for exacerbation. Therefore, please, my colleague, take care. Don't advise the antiviral therapy except when it is indicated. Because if you start the treatment, nobody can stop it. Now, there is problem. Patient with HCV positive, HBV positive co-infection. Treatment of HCV when the HBV is not active. Treatment of HBV when HCV is not active. If both are active, how to know the activity by PCR? Therefore, if the PCR for C positive and for B negative, we treat hepatitis C virus. If PCR for C negative and for B positive, we treat the viral B. When both are positive, we consider treatment both together. The best for treatment of both is interferon-based therapy. At that time, the combination may be more benefit interferon with lamivudine. If you have hepatitis B virus and hepatitis D virus in Egypt, يعني hepatitis D virus away from our mind. We don't search for it. But if you search for it, you may find is positive. How to search for it? To ask for HDV RNA. If it is positive, the treatment by regulated interferon. And for 3 to 6 months, if there is response, go on for 72 weeks. But the oral antiviral therapy not benefit except when the HBV is positive. At that time, we should treat the active HBV replication only. Therefore, we are confronted by some cases, a case of renal insufficiency, going on dialysis, or want to have renal transplantation. All patients with renal dysfunction should be screened for viral B hepatitis. Seronegative patient should be vaccinated. When it is present, we treatment of choice entecavir, not tenofovir. We adjust the dose of entecavir as regard the urea clearance. Now, we are confronted by other problem. Pregnant patient. All pregnant females should be screened for surface antigen. Pregnant women in the last trimester, when the PCR is more than 2000 international unit, they are candidate for antiviral therapy. The best treatment for a pregnant woman, 2 drugs, lamivudine 100 milligram or tenofovir 300 milligram once daily. And it is given in the 3rd trimester, continuing the antiviral therapy for 3 months after delivery to decrease the chance of newborn infection. What is about the newborn? The newborn for chronic hepatitis B mothers should receive at birth within 6 to 12 hours at most after delivery. Vaccination against viral B hepatitis. What is the problem if you give the mothers in the first trimester? Is it dangerous? No. The lamivudine defects of live births only 91 in 3089. That is to say 2.9%. Tenofovir 14 in 606 patients. That is to say 2.3%. Adefovir, we don't give Adefovir, Entecavir, Tenofovir. Therefore, the pregnant woman should screen for the virus and to give the treatment in the third trimester. It is important. The breastfeeding in the viral B mothers. Hepatitis B can be detected in breast milk. Breastfeeding is allowed for neonate after vaccination. Safety of antiviral therapy during lactation unknown. Antiviral therapy can be detected in the breast milk. Therefore, the virus can be detected in the breast milk and the treatment can be detected in the breast milk. Therefore, you lactate your neonate or not. Therefore, we cannot say no breastfeeding because the breastfeeding is very important for neonate. And we cannot that it is safe because till now we cannot say it is completely safe. What is about acute viral B hepatitis? How do you know acute viral B hepatitis? When you find HBsAg positive. This means acute hepatitis. The surface antigen by itself is not important as HBsAg. When the HBsAg positive, it means acute hepatitis B virus infection. There is spontaneous recovery in more than 95%. Seroconversion to anti-HBs without antiviral therapy is possible. Supportive management and close monitoring for fulminant hepatitis. How to follow up by prothrombin concentration. When there is fulminant hepatitis, therefore, at that time, we advise entecavir half milligram continued for at least 6 months after HBsAg loss and anti-HBsAg positive or for at least 12 months after seroconversion to anti-HBe without HBsAg loss. Therefore, the question, is there a cure from hepatitis B virus infection? The existence of HBV cDNA and integration of the virus into the host genome make it difficult to achieve cure from hepatitis B virus. Even in patients recovered from acute hepatitis B virus infection with HBsAg conversion to anti-HBs. HBV DNA persists in liver and can be reactivated upon immunosuppression. Therefore, the vaccination is highly recommended for women and men going to be married, for women going to be pregnant, for healthcare worker, for the people in contact with a patient with hepatitis B virus, in chronic renal failure patients, in patients start renal dialysis, in patients with hepatitis C virus, immunosuppressed patients, patients receiving multiple blood transfusion. Therefore, in conclusion, with the development of the potent antiviral drugs with low resistance to treatment, long-term treatment is effective in continuing the PCR suppression at more than 90% of patients associated with histological improvement. Loss of surface antigen occur only about 10%. Treatment may be lifelong. Therefore, we can say now, take home these messages. Treatment of chronic hepatitis B rely on evaluation of 3 parameters: viral load, ALT, severity of liver disease. All cirrhotic patients with HBV viremia should be treated irrespective of viral load. Renal insufficiency, entecavir preferred with dose adjustment according to creatinine clearance. The breastfeeding in hepatitis B mothers can be detected, the viral B can be detected in breast milk. The antiviral therapy can be detected in breast milk. Safety of antiviral therapy during lactation unknown. Breastfeeding is allowed for neonate after vaccination. High viral load increased risk of hepatocellular carcinoma prevented in patients with chronic hepatitis. Hepatocellular carcinoma not prevented in those with cirrhosis. Hepatitis B virus patients with cirrhosis who respond to LAM still developed hepatocellular carcinoma. The surface antigen quantitation predicts risk of hepatocellular carcinoma when it is more than 1,000 in 95% of cases. We are waiting for new therapy that can clear cccDNA, which means clearance of surface antigen, which means cure from hepatitis B virus infection. And thank you very much.